Hello, everyone. I'm Dr. Jiansing Ling from the ultrasound department of the 3rd Affiliated Hospital of the Sun Yat-sen University. I'm honored to demonstrate the operation of pelvic floor ultrasound with you today. After emptying the bladder and rectum, the patient lies in the dorsal lithotomy position. First, we have to choose the probe. Click the probe icon on the touch screen. We used Mindray Volume Transducer D8-2U for this scan. Then, select a dedicated pelvic floor ultrasound preset. We need to fully cover the probe surface with gel. And also, you can use this type of gel as much as possible. In this way, ultrasonic artifacts can be avoided well. We usually choose this type of probe sleeve on the probe. It is necessary to ensure that the probe sleeve fits closely with the probe. Now we need to completely cover the gel on the surface. We use this disinfectant gel, or sterilized gel. As before, use as much as possible. Next, the probe is placed in the patient's perineum. The marker of the probe is upward. At this time, we get a standard sagittal section of the pelvic floor. So, you can see here, on this sagittal plane, we can see the symphysis pubis, urethra, and anal canal. These three are the structures that define our standard sagittal section. At this time, we also need to pay attention to one thing. That is, the distance between the surface of the probe and the symphysis pubis should be less than 1 centimeter. Only in this way. First, it can ensure that our image quality is relatively good. Second, it can also ensure that we will have good repeatability of measurements on this image. In this case, you can see a lot of gel entering the vagina. For some patients with vaginal laxity, when the probe is placed in the perineum, the gel will enter the vagina. That's what we suggest that we use this disinfectant type of sterilizing gel on the surface of the probe. So, after obtaining the standard mid-sagittal section of the pelvic floor, we can see here is the patient's bladder. About residual urine volume, RUV measurement. Generally, we require measurement within 10 minutes after the patient emptying the bladder. Like this case, you can visually find that the residual urine volume, RUV, is not much. Generally, when the residual urine volume, RUV, is less than 50 milliliters, clinical treatment is not required. In addition, parameters to be measured probably is the detrusor wall thickness. So how to measure the detrusor wall thickness? Generally, we choose the section perpendicular to the bladder top and the probe. Measure the distance from the mucosal surface of the bladder wall to the serosal surface. When we measure the detrusor wall thickness, we have to measure 3 times, then select an average value, about this parameter. Generally, if there are no special needs in the clinic, we don't need to measure, because the detrusor wall thickness is only related to some specific diseases. So, about the measurement of detrusor wall thickness. As long as we know this method, we can choose when there is clinical demand. Okay, we now store this image of the patient at rest. Press the Save button. At this time, we need to measure the organ position in the resting state. Enter the Smart Pelvic preset and click the Rest frame on the touch screen. If you need to measure more parameters, you can click the measurement item on the touch screen, which will display more measurement parameters. All the parameters you measured will also be displayed in the lower right corner of the screen. Then measure 1 by 1. bladder neck, urethral inclination angle, the location of the cervix, the location of the rectal ampulla. Then press Save button to save the measurement in the resting state. After this, we examined levator ani muscle in parasagittal view. You can see that this is the levator ani muscle. When we move the probe sideways, we follow the direction of levator ani muscle, and then move the probe sideways to observe. Pay attention. Okay, the levator ani muscle is shown very clearly for this case. Well then, we ask the patient to do a pelvic floor muscle contraction. Good. Contract your anus. Contract. Very good. Okay, relax. Here we examine the levator ani muscle on the right side. So we'll mark this as the right. Store image. Press the print key to save the sign loop. Press the clear key to remove the text mark. Then we place the probe in the mid-sagittal plane and move the probe to the left side to observe the left levator ani muscle. Okay, tilt the probe to the left. At this time, we can see the left levator ani muscle clearly displayed here. Okay, contract your anus. Contract. Okay, relax. This is the left levator ani muscle. Okay, after observation, levator ani muscle, press the print key to store the parasagittal section we just obtained of levator ani muscle image. Next, we activate the 4D to observe the levator ani muscle. Press the Update button. Okay, let the patient contract the anus. Okay. Please contract your anus. Good. Relax. Okay. At this time, we can click Open, Closing, Closed on the touch screen. In this way, we can obtain the image of symphysis pubis open, closing, closed from IUGA guidelines. MindRay's machine gets it automatically. Open, closing, closed, 3 conditions. Click 3x3 on the touchscreen. Then, the image shows the standard axial plane of the levator ani muscle we obtained. Then, in the axial plane, we can judge the continuity of levator ani muscle. Pay special attention to the 3 images in the middle, whether the levator ani muscle is continuous. If all the levator ani muscles in the middle 3 images are avolution, it is a complete avolution of the levator ani muscle. If only 1 or 2 of the images are avolution, it is a partial avolution of the levator ani muscle. In clinical practice, partial avolution of levator ani muscle will not cause obvious clinical symptoms. So, for partial avolution of levator ani muscle, we don't usually make a diagnosis. Now, press the Save key to save. Store Open, Closing, Closed images. Press the Print key to store the whole contract process 4D sign loop. OK. Next, we will observe the integrity of the anal sphincter. The probe is rotated 90 degrees transversely and tilted back and tail. At this time, we get the oblique coronal plane of the anal sphincter. Activate 4D and press the Update button. Ask the patient to do a gentle contraction of the anus. Good. Very good. Press the Print key to store the 4D image just obtained. Then click iPage on the touchscreen. Rotate the Zoom key to enlarge the image. Adjust the X-axis knob. Display the anal canal horizontally on plane B. Next, click the button on the right-hand side of the trackball. Then we can move the image of the section. In this way, the full length of the external anal sphincter can be included. Then, the indicator plane we see is the dorsal external anal sphincter. There is a hypoechoic-like fascia structure between the dorsal external anal sphincter and levator ani muscle that we can distinguish the external anal sphincter from the levator ani muscle. Okay, it's better to enlarge the image for observation. We can also move our reference plane. Here is also a reference line setting here. You can see, for example, I have set a point here at the distal end of the anal sphincter. If only the proximal anal sphincter is not included, I can click this button, then move position until it can include the full length of the external anal sphincter. So you can see, this operation is very convenient. Now, let's look at the image of the anal sphincter, this image. When we want to judge whether the anal sphincter is injury, generally, we'll look at these 6 images. The current standard is that 4 images have defects. At the same time, the angle of defect should be greater than 30 degrees. If like this, a tear of the anal sphincter can be diagnosed. If not, generally, this partial tear of the anal sphincter will not cause obvious clinical symptoms. So we usually don't make a diagnosis. Now, click Save to store the image of the axial plane of the anal sphincter just obtained. Stored image. Okay. Then we rotate the probe 90 degrees. After the probe rotates 90 degrees, let's go back to the mid-sagittal section of the pelvic floor. The next thing to do is ask the patient to do the Valsalva action, like a pregnant mother bearing down while pushing during labor. At this time, we can click the print key first, store sine loop backwards, so in the lower left corner of the screen, we will see the storage progress display, show here. When the patient is doing Valsalva, we ask the patient to last at least 6 seconds for Valsalva action. So when doing Valsalva, we need to check whether the time action lasts enough. Ready? 3, 2, 1, go. Push, push, push. Push, push, push. Good. Very good. Okay, freeze. Images are automatically stored. Then let's click Replay button. Play back until the frame of the maximal Valsalva action. Then we stop the image. Select Smart Pelvic Valsalva frame on the touchscreen. Then at the bottom right of the screen, a schematic will appear. The schematic will give you a hint. What are the parameters we need to measure next? The horizontal line signifies the inferior margin of the symphysis pubis. This is our reference line, and position of bladder neck. Retrovesical angle. Position of bladder. We can all measure 1 by 1, and also position of cervix. Because in the process, there is no obvious prolapse of the uterus, so we don't need to take a measurement of the uterus. Then click the Update button. Then it will automatically jump to the next measurement, that is, the rectal ampulla. Okay. Then click the Save button to save all the measured parameters just now. So, in the process of Valsalva action, we should pay attention to the following 2 points. The first is that the probe cannot be deflected. Once the probe deflects, it will be difficult to obtain these indicators, such as whether the internal urethral orifice has funnel formation, and where is the position of the bladder neck. The second thing to note is that pressure should not be applied to the patient's perineum. If the probe is forced against the patient's perineum, then the prolapsed organs are likely to be pushed back into the vagina under your pressure. So, in this case, we underestimate the extent of organ prolapse. If it's in the process of Valsalva's action, we note the above 2 points. The final judgment on the degree of prolapse of the patient will be the most objective. Okay, next we activate 4D again. Measure the area of levator hiatus under Valsalva action. Click the Update button. OK. The system will automatically detect the minimum plane of levator hiatus we need. Here is symphysis pubis. At the same time, the system will automatically adjust the size of ROI. Thus, it provides us with the best rendering image for the area measurement of levator hiatus. Okay, next, let's ask the patient to do a Valsalva action. Ready? 3, 2, 1, go. Push, push, push. Push, push, push. Push, push, push. Good. Press the Print key to store the image. At this time, we can click the Smart Pelvic on the touch screen. The system will refresh the render direction automatically. OK. Then the area of levator hiatus will be measured. The measurement results will be displayed automatically. Here we can see it contains the inferior margin of symphysis pubis and levator ani muscle. At this time, we obtain the area of the levator hiatus under the maximum Valsalva frame. And also, if you think the automatic measurement of levator hiatus is not accurate enough, we can also click Edit on the touch screen. Then it will enter the editing state. We can start editing until you are satisfied. The measurement results are also displayed in the lower right corner of the screen. Press the Save button to save the measurement results just obtained. This is the whole pelvic floor ultrasound scanning process. Thank you.